You submitted the claim. You did the work. The patient improved. The notes were done. And still denied. If you've been in physical therapy practice for more than a month, I am sure you've seen this. And if you're a clinic owner or a biller, you've probably seen it more times than you'd like to count. Here's the thing nobody tells you when you're starting out in PT billing. Most denied claims have nothing to do with the quality of care that was delivered. The patient needed the therapy. The therapist was skilled. The treatment worked. But somewhere between the treatment room and the insurance payment, something broke down. And that breakdown almost always falls into one of 5 categories. In this video, I'm going to walk you through each one in plain English. No jargon, no complicated billing talk. Just the 5 most common reasons PT claims get denied, and what you can actually do about each one. Let's start from the beginning. Reason number 1, nobody confirmed the patient's insurance was active. This one is the most common, and it's painful because it happens before you even see the patient. A patient gives you their card. It looks fine. You schedule the visit. You treat the patient, you submit the claim. Denied. Why? Because that patient's insurance coverage wasn't actually active on the day of the visit. Maybe they changed jobs and their new insurance hadn't kicked in yet. Maybe they missed a premium payment. Maybe their employer switched plans at the start of the year and nobody told them. It happens all the time. And the tricky part is, an insurance card doesn't tell you any of that. A card just tells you who the patient's insurer is. It doesn't tell you whether coverage is currently active. It doesn't tell you what the deductible situation looks like, whether PT requires a referral under that specific plan, or how many visits are covered. That information has to be verified directly with the insurance company. This is called eligibility verification. And the problem in most clinics is that it gets done once, usually at the very first visit, and then never again. But insurance status changes. A patient who was covered in January might have a lapsed policy by March. If your clinic isn't re-verifying before every visit, you're treating patients on the assumption that nothing has changed. And when it has, you find out through a denial. Reason number 2, a required code was missing from the claim. In physical therapy billing, claims don't go out with just a diagnosis code and a treatment code. They go out with modifiers. Think of modifiers as small 2-letter codes that get attached to the claim to give the insurance company additional context about the visit. In PT billing, certain modifiers are required. The first is the GP modifier. Every single Medicare outpatient PT claim needs a GP modifier attached. It's how Medicare knows the service was provided under a physical therapy plan of care. No GP, no payment. It's that simple. The second is the KX modifier. Medicare sets an annual spending threshold for therapy services. Once a patient crosses that threshold in a given year, the provider has to attach a KX modifier to every claim going forward. The KX modifier is essentially your confirmation to Medicare that, yes, this patient still needs therapy. Yes, my documentation proves it. Without it, after the threshold is crossed, the claim gets denied. We made a dedicated video on the KX modifier link in description. The third is the 59 modifier. When you bill more than one procedure code on the same visit, certain combinations will get automatically bundled by the payer, meaning they'll only pay for one of them. The 59 modifier tells the payer that these were separate, distinct services that each deserve their own payment. Now, here's why this matters so much. Most clinics are tracking these modifiers manually. Someone is watching a spreadsheet. Someone is checking a threshold number. Someone is trying to remember which patients need KX this month. And people miss things because they're human. The most reliable way to catch modifier errors before a claim goes out is to have a billing system that checks for them automatically. One that knows when a Medicare patient has crossed the threshold, adds KX without anyone having to remember, and flags missing modifiers before submission. Reason number 3, the time was billed incorrectly. Physical therapy uses something called timed CPT codes. These are codes for specific treatments, things like therapeutic exercise, manual therapy, neuromuscular re-education, and the number of units you bill is based on how many minutes were spent providing that treatment. Medicare has very specific rules about this. It's called the 8-minute rule. Here's how it works in simple terms. You need to spend at least 8 minutes on a timed service to bill 1 unit of it. You need to spend at least 23 minutes to bill 2 units, at least 38 minutes for 3 units, and so on. So if you spent 10 minutes, that's 1 unit. 22 minutes, still 1 unit. 23 minutes, now you can bill 2. The math sounds straightforward, but when you're treating 15 or 20 patients a day, billing multiple timed codes per visit, and trying to document everything accurately, it gets complicated fast. The most common mistakes here are rounding the time up slightly to get an extra unit, which looks like upcoding to an auditor, not clearly documenting how many minutes were spent on each specific treatment in the note, which means the billing doesn't have documentation to back it up, or just applying the rule incorrectly because whoever is doing the billing wasn't trained on it specifically for PT. The result is either a denial on submission, or worse, a payment that gets taken back months later after a review. Your billing has to match your documentation. The minutes in the note have to match the units on the claim. Every time. Reason number 4. The notes didn't prove the patient needed therapy. This is the one that feels the most unfair, because the patient did need the therapy. You know it, the patient knows it, but the insurance company doesn't take your word for it. They look at the documentation, and if the documentation doesn't clearly show that the treatment was medically necessary, they deny the claim. Or they pay it, audit it later, and ask for the money back. Weak documentation sounds like this. Patient tolerated treatment well, continued with plan of care. That tells the reviewer almost nothing. It doesn't show what the patient's current condition is. It doesn't show what improved. It doesn't show why a trained physical therapist, rather than a home exercise program, was required. Strong documentation sounds like this. Patient demonstrated improvement in right shoulder flexion from 110 degrees to 135 degrees following manual joint mobilization and rotator cuff strengthening. Patient continues to require skilled PT intervention to progress loading parameters and correct compensatory movement patterns that would not be detectable or addressable through independent exercise. See the difference? The second note tells a story. It shows where the patient started, where they are now, and why the therapist's skills, not just exercise, were what got them there. That's what insurance reviewers are looking for. Specific measurements, functional progress, a clear reason why skilled therapy is still required. This applies to every patient, but it becomes especially important for Medicare patients who have crossed the annual spending threshold. Because at that point, the documentation isn't just a clinical record, it's your evidence that continued care was justified. Reason number 5, prior authorization wasn't in place or ran out. Prior authorization is exactly what it sounds like. It's the insurance company's permission slip. Before some insurance plans will pay for physical therapy, they require the provider to get permission first. You have to submit clinical information, the diagnosis, the treatment plan, the number of visits needed, and the insurance company reviews it and says yes or no. If they say yes, you receive an authorization. That authorization covers a specific number of visits, or a specific date range, or both. Here's where claims get denied. The first way is straightforward. Someone didn't know authorization was required. The clinic started treatment without it. Every visit, denied. The second way is subtler. The clinic got the authorization for 12 visits. The patient reached visit 12. The therapist kept treating. Nobody renewed the authorization. Visits 13 and 14, denied. The third way is a details problem. Some payers authorize by visit count, some authorize by date range, some authorize by units. If your billing team doesn't know exactly what terms each authorization was issued under, they can't catch when it's about to expire or be exceeded, and payers are not going to call you and warn you. The denial just arrives. Managing prior authorizations well requires knowing, for every active patient, every payer, every plan, what's authorized, how much of it has been used, and when it needs to be renewed. For a clinic with a full caseload, that's a significant administrative task. And when it's tracked manually, things fall through. If you look at all 5 of these reasons together, you'll notice something. None of them are about the quality of care. These are operational breakdowns. Gaps in the workflow between the treatment room and the payer. They're happening in clinics everywhere. Not because people aren't trying, but because physical therapy billing is genuinely complex, and most clinics are using tools that weren't built specifically for PT. The average first-pass claim acceptance rate in PT, meaning the percentage of claims that get paid without any rework, sits around 85 to 90%. A well-run PT billing operation should be at 95% or higher. That gap, 5 to 10% of claims needing rework, is real money, real time, and real administrative burden that adds up every single month. If denials are a consistent problem in your practice, start by pulling your denial reports from the last 90 days and categorizing them by reason code. You'll almost always find that 1 or 2 of these 5 categories are responsible for the majority of your denials. Once you know which category is driving the problem, you can fix the workflow specifically for that issue. Eligibility denials mean you need automated verification running before every visit, not just at intake. Modifier denials mean your system needs to be enforcing PT rules automatically. Time billing denials mean your documentation needs minutes per service. Medical necessity denials mean updated templates for measurements and progress. Prior auth denials mean you need a tracking system, per patient, per payer, that alerts you before authorizations expire. Tools like SPRY are built specifically for this, automating eligibility verification, enforcing modifier rules, tracking prior authorizations, and scrubbing claims before they go out. It's the kind of infrastructure that moves a practice from reactive, chasing denials after they happen, to proactive, catching problems before the claim is ever submitted. The goal is fewer denials and faster payment. To recap, Reason 1, eligibility. Reason 2, modifiers. Reason 3, time billing. Reason 4, medical necessity. Reason 5, prior authorization. 5 reasons, all preventable, all fixable. If this was helpful, subscribe for more PT billing, compliance, and practice operations content explained in plain English, specifically for US physical therapy practices. If you've got a denial scenario you're dealing with right now, drop it in the comments. We read every single one. Thanks for watching. See you in the next video.